Next, we are privileged to have Cynthia Ambres, Dr. Cynthia Ambres, who's the National Lead Advisory Partner from Strategy Group for KPMG. She's a regular speaker on these multiple topics. She's authored a lot of good information about this, including contracting value, paying for volume versus paying for value, transforming systems, addressing the cost of care, and leading a path to success. So without further ado, Cynthia, you are up and on.
Hi. I'm going to just start by saying a comment to Sam's talk, which I thought was definitely a great opening. And, Sam mentioned that he thought it was not the regulation that drove the change, but the economics that drove the change. And I would challenge that to say, I think it was the economics that drove the regulation, that drove the economics, that drove the change. And I say that because I've been in healthcare for 30 years as a provider and administrator, and sort of been all over the map by way of background. I'm an emergency medicine physician. I've been a chairman of an emergency department in Beth Israel in New York, and then went on to be a chief medical officer at 2 Blues plans. So I like to say I've seen clouds from both sides now, and it's been an interesting journey, but clearly a time of tremendous change, which is actually very exciting to me because I came up in a time where when I first went onto the payer side, I was sort of very disappointed with what was sort of possible. And I think that I'll talk a little bit about that in a minute, and I'll start out by just concentrating on what the topic at hand I was asked to talk about was first, which is the payer landscape, why consolidation, why this is happening, and why we're seeing this integration. So for me, there are sort of 3 things, or many things that are impacting the consolidation on the payer side, but I'd say there are 3 major drivers, and all associated with sustainability, right? So the first, I think, are new growth strategies. So everyone needs to think about, on the payer side, new growth strategies, and they're thinking about it in the terms that Sam discussed, which is I need to have a robust portfolio that is diverse to stratify risk. I can't just be in commercial insurance anymore. I've got to have Medicare. I've got to have Medicare Advantage, which probably is a positive still. I've got to have Medicaid, where before, payers were very selective about those buckets, if you will, and decided sort of at will which place they decided to swim in, depending on the years and what the rates looked like and what was happening in the trends. But now, just about everybody realizes that we've got to be broad and we've got to stay broad to be successful. And the issue there, of course, is if you start doing Medicare and Medicare Advantage, do you actually know how to play in that sandbox? Do you know how to take care of those patients? And Sam touched on that as well. It's not that easy, and it's not the same as a commercial population. And, providers are seeing the same thing, quite frankly, when they expand and merge. They start to look at different populations and say, gee, we were very comfortable with this population, but now as I go into North Country or south of here, things are changing, the demographics are changing. I have to market differently. I have to think differently about what those people want because of another driver, which will be consumerism that I'll talk to, and what they need from a provider or provider payer or just a payer. Secondly, I think there's a need to think of margin maintenance, I like to call it, right? So even as revenues are shrinking, and again, Sam talked about this topic, as revenues are shrinking, people are still trying to hold on to their margin, and these margins have always been traditionally very skinny. So it's about, can you hold on to your margin? Can you potentially increase your margin? And how are you going to go about doing that? This is where sort of the very hard work and the reality of cost of care comes in, right, on the payer side. So the payers have for many years been dealing with the idea of managing care in some way, shape, or form. They went in and out of vogue. First we had capitation, that became a dirty word, and then we moved into HMOs and managed care. We used to call, when I was in the managed care side, we used to call, managed care capitation and drag, and I guess now we can say value-based payments are managed care and drag in some way. But it is sort of the same kind of thing, if you will, that we know we need to do in terms of looking long-term at how much the total cost of care is, and that this driver, which is the most difficult driver to deal with, has to be dealt with finally. And it's been sort of, the low-hanging fruit is kind of gone. This is an area where people are not doing very well still traditionally across the country, although there are pockets where people are looking at evidence-based medicine and doing good work around this, but not everywhere. But we know that in 1990 to say 2003, the healthcare cost curve was clearly bent by HMOs, but the process was broken and it strained relationships and people just kind of, quite frankly, got tired of it and sort of gave up. Now it's about engaging providers in new collaborative relationships, and this is a challenge because so how do you do that with a shrinking pie? Everybody wants to get paid more, the companies want to make more, the providers clearly think they're making too little. So we're not making the pie any bigger, but we have to think about this in terms of a reallocation. I liked, David Nash's catchphrase, which is the value-based contracting, which is, no outcomes, no income, right? So we're not quite there yet. We're seeing things like that are successful, decrease in 30 days readmission, inappropriate readmission after 30 days. That is an example of an outcome that is of value. But when we sort of look at that bigger work of individual physicians, their value, what they're contributing, and what they should be paid, that's a much harder thing to sort of delve into. And we're starting to see startups and companies rising up around this concern and trying to meet these things. Companies like MD Insider, who are saying, we're going to show you, we're going to be transparent about physicians, and we're going to link their facilities that they work in, their outcomes, their complication rates, and actually show this to the public. And that's a difficult thing for us to swallow. It's hard for physicians to swallow it. It was always a challenge on the payer side because these questions were always being asked. So I can say in the 90s, when I started in that business on the payer side, I would have physicians come into my office and they'd say, Cynthia, I am better than the guy down the street. I have better outcomes, I'm giving better care, and I should be paid more for that. My answer to them was always that that's true, you really should be, but we do not have the methodologies or the systems or the reimbursement methodologies set up at this time to reward you in that way. We had data, and we've had a lot of data for a long time. We didn't quite know how to aggregate it properly. We certainly didn't know how to synthesize it properly. But more importantly, there was regulation, and there still is, for the payers are not allowed to just rate doctors because there was always this distrust of the payer, right? The insurance side was always distrusted, and it was as if, well, you're doing it in a malevolent way. If you start to rate doctors, you're going to rate them on the basis of cost. And that's what patients are going to see, so they're going to be valuing the wrong things. So for me, this disruption that's causing this change is very valuable. And I think that we're going to start seeing, and we are starting to see, this shift toward really looking at what we're getting for our dollars. But this is not a thing that's going to happen in a very short horizon. So as much as we talk about value-based contracting, whenever I go into clients, very successful, actually, provider clients, and talk to them about, your bundles, you tried bundles last year, I see you abandoned them, you're doing a little value-based contracting, where are you going in the next year? They say, well, we're not really seeing that too much of that in our area. We want to try it, and yet we hear the secretary saying by 2018, all CMS products will be in some kind of value-based contracting. 50% of them will be by 2018. That's quite a big number. And from my point of view, and I'm sure many on this panel would say, when you go out in the real world, I'm just not seeing it. I don't see how it's almost possible for us to get there. So that concerns me about sort of sustainability. Thirdly, I think it's the need for a consumer-focused approach. This is a big deal, and it sounds like, again, a lot of catchphrases and words around this that people talk about. Oh, we're going to be consumer friendly, we're doing this and that, we changed our signage. But at the end of the day, Has it made a difference? We changed the name. We spent $3 million changing the name of the organization. It sounded better to people. We did some focus groups, And, I go back to another comment Sam made. When you do focus groups, you find out all kinds of interesting information, even in brands that were somewhat trusted at a time. We did a focus group back in Blue Cross Blue Shield many years ago, and we had patients come in and we talked to them, and consumers come in and we talked to them about the emblem, the cross and the shield and everything. And very interestingly, about 8 out of 10 people said that the thing that stood out to them in that emblem the most was the snake. So, when you're thinking about being, the trusted resource, that's not exactly the brand that you might want. So what are consumers looking for? They're looking for ease of use. Ease of use. And that's where we're just not there. We're not at ease of use. The EOB, what the heck is that? We all have to deal with it. And, I would venture to say, pretty smart people in this room, just think about what the average person is dealing with, or what an elderly person is dealing with, or someone who has difficulty reading or difficulty understanding English does with some of the ways we communicate, especially from the payer side, with our patients. And then we say, this is not a bill. Why the heck not? Make it a bill. Make it easier for me. It has some value to me if it's a bill. Then I know I have to pay something. And I guess I didn't have a fourth one, but I'll say the fourth one since Bob mentioned it. Is it a CEO ego thing about being bigger? I think sometimes it is. Sometimes it is. I was involved in a discussion around a merger. Won't talk about the companies, but I will say that the degradation and the incompletion of that merger was all about CEO egos. It had nothing to do with the possibilities of what those companies could bring to those communities if they had joined, which was significant in that community. So we do have that as well. So, I look at this and I say, what are insurers kind of hoping for? It's not unlike what providers are hoping for, right? Beyond sort of simple potential economies of scale, they want to, or should want to know, does their partner offer something that they don't have beyond new geographies? It used to be just about that. Let me just go into a new geography and get more people. Whether it be the front office, like innovative product design, do they offer perhaps new consumer marketing strategies? Or perhaps middle office capabilities, like success in the value-based contracting market? Do they have effective network design? These are the kinds of things that are important in vetting a partner, and sometimes we don't see that. We really still see geography, we see scale. But scale alone is not going to save you in this industry. I'll talk a little bit about skinny networks, but that's an area where I think it's important for people to be thinking about skinny networks. Skinny networks got a sort of a bad name. I think that was very much related to the fact that they were originally designed around cost and just driving the cost to be cheaper from the payer side. And what people were hoping for was that you'd see superior physicians who were practicing perhaps evidence-based medicine that would drive costs lower. And if you can design a skinny network, in fact, that's based on that kind of reality, then you have something. There's back office opportunity, customer care approaches, there's home care devices, monitoring, all kinds of personal coaching, these kinds of capabilities we need to have. Now, coaching and also, sort of getting into the home and monitoring people is a difficult issue sometimes as well for both provider and certainly for payer, because again, there's distrust of the payer. So do I want a payer in my home monitoring my every move? Do I trust that to be the case? Is that going to cause my premiums to go sky high the next year when I re-up my insurance? Lastly, I'd like to just make a point about organizational culture, because I think people don't think about organizational culture compatibilities when they do a merger as well. And so that is that's a mistake, of course, because we have certainly seen that cultures that do not come together, and again, this is both payer and provider side, are very difficult integrations to make successfully, And so there is, that's kind of a last-ditch effort. Usually it's the bottom of the list. When you talk about that with clients, it's like, oh, the culture, yeah, okay. Thanks, Cynthia. Thanks for bringing that up. But these are all potential concerns for the right partner. The regulatory hurdle is the next jump, right? So we're seeing this play itself out in real time. And Bob mentioned Aetna and Humana and Anthem and Cigna. And if you read the testimony, aside from those of the principals that was put in front of Congress in September, you see some very interesting things. I looked at policy folks like Dr. Ginsburg of USC and Dr. Daphne of Northwestern, who presented statements challenging whether consolidation would drive premiums lower and be of benefit ultimately to the consumer. They both stated that though the mergers may result in lower payments to providers, the savings may never be passed on to the consumer by way of lower premiums. So they are basing this on historical trends, which is nothing wrong with that. We have to try and learn from history sometimes. So we do need research to test and to substantiate evidence of actual cost trimming in the long term should these mergers go forth. You know, they're going to need to be monitored, and I believe that that will be part of the stipulations that if the DOJ allows them to go forward, there will be some stipulations around that. There is concern as to whether new entrants, also by these experts, into the market are likely to offset some of the consolidation. They're concerned that new entrants aren't going to really have a chance. And that is a concern that we should all be thinking about, although I am really intrigued by some of these new companies. And it's kind of exciting what's happening since we hadn't seen a lot of new entrants into the payer market for a very long time, until fairly recently. One that is very innovative and catchy, advertising in Southern California, you may be starting to see some of it. They started in New York, I believe, and then New Jersey. Now they're in Texas and Southern California, and they're called Oscar. Have people been seeing, you know, signage and marketing around there? And their .com is hioscar.com, and they say smart, simple health insurance. That's what we are. So I went to their site and I found it frightfully easy. It was incredible. You go in, you have literally a big screen. The font is big enough for me to see without my glasses. And it was wonderfully easy, intuitive website. Literally filled out 5 fields, and the second page is my information. Plan selection with pricing. Try that with any of the big insurers. It's not going to happen. They were started in 2012 by 2 IT guys who were sitting around, 3 IT guys actually, but 2 were talking about their experiences. One's wife was having a baby. The other had, I think, fractured an ankle and gone to the ER and had a horrific time communicating with the doctors and then getting the bill, and the family that was trying to just figure out who the best OBGYN was, couldn't get any information. You know, they were just saying, this seems like we can do better. Can we do better? So they started Oscar. In April, they raised $145 million with $1.5 billion valuation last April. And in September, Google Capital invested $32 billion, raising their valuation to $1.75 billion. However, they've struggled with high administrative cost and low enrollment, not unexpected, obviously, for a new insurer. And then I think the other issue is that they're going direct to consumer, so they have a broker issue. I mean, they don't have brokers, so they can't go to employers. So they need to probably develop broker relationships. So that helped drive, I think, a $35 or so million loss last year for them. Again, not a huge loss in the insurance world. An interesting quote I saw by the CEO, though, who was recently interviewed, said something interesting. He said, I wake up every morning and I go, we're 3% done. So that's important. They know what they don't know. I think that that's something that's not true of a lot of the large insurers. They think they've just got it, really. They just have to keep doing it more. And there's a problem with that. We see it in everything, especially on the side of consumerism. So these companies are trying to be pioneers in customer relations. As an example, one of the things I talked about before already is that they tried to provide, Fitbits for all of their customers, and they wanted to help with coaching and everything. And people were like, then if I'm not fit and I'm not walking and I'm a couch potato, do I get higher premiums next year? So people are still a little gun shy, even of new insurers that sound very friendly. So these things are par for the course for a new startup, but I think that they are learning very important lessons. I remember a few years back when a number of provider clients were standing up saying, oh, I want to become an insurance company. And that was until they did their due diligence. So we would go in and we'd do a gap analysis and we'd say, this is where you are, these are the capabilities you need. And it would be, you know, this chiasm that was impossible to cross. And they'd say, you know what, maybe not, maybe we'll do a relationship, maybe we'll do some kind of partnership or a payer-provider entity. And I think that's probably a more successful space for most providers, not sort of jumping off into just their own insurance company. Another company that caught my attention was Clover Health, and they're providing Medicare insurance. They're in the state of New Jersey. I liked them because their focus is on care coordination, and that's all they advertise. It's like, we provide better care at lower cost. Very simple. That's their first screen when you go in. And they have an older gentleman smiling. That sounds good, right? Better care at lower cost. And then again, next screen, simple, identification of certain items that they need. Third screen, starting on pricing and plans. So not a new care methodology, obviously focusing on care coordination, but when you do that with a circumspect population, you can be successful. LumaD is another one. That's a broker style. They're assisting employers and employees, and they provide software basically to help with plan benefit and provider decisions. And then another kind of interesting one is Zoom, which is a payer and a provider. They started all the way back in 2006 in Portland, Oregon. And I just love them. I actually went to one of their places because I was with a friend in Portland and she sprained her ankle. Really beautifully aesthetic, you know, beautiful aesthetics when you walk in, very, very patient-friendly environment. And then they realized they could also do insurance, and they started to do a little bit of a time. And their mantra is a new breed of health insurance is in town. So they're targeting, I think, more the young, tech-savvy kind of consumers. An example of a plan type in Zoom is called Plus Prime, and that includes something called food and movement as medicine classes. So they've got, you know, they've got that new language, they've got sort of the Zen kind of yoga feel that people are interested in, especially in Portland. So their thing will be, you know, what will happen when they go outside of the Pacific Northwest. So in closing, you know, these are exciting times. I'll say that again for me, 30 years in healthcare, I've never seen more change, and I'm excited by this change because I am very hopeful that maybe, just maybe, the current chief medical officer at my old Blues plan will be able to fully compensate that highly quality physician for better outcomes after all. And in the words of Winston Churchill, Americans will always do the right thing after having tried everything else.